Good afternoon, everybody. Welcome to this glaucoma session of glaucoma potpourri. So I'm going to talk about MIGS, the incisional goniotomy, Phaco plus bang or KDB, or no financial disclosures. The phrase MIGS was coined by Dr. AIOCMT3. He has revolutionized the glaucoma management with minimal tissue trauma, good post-operative recovery, and improved patient satisfaction. So what is the definition of MIGS? Basically, MIGS constitute a group of surgical interventions which share 5 common characteristics. They should have high safety profile, they should be minimal disruption of the normal anatomy, we should have an ab interno approach, and the efficacy of MIGS should offer meaningful lowering of IOP, and they should be easy for both the patient as well as the surgeon. So there are various approaches for MIGS procedure, but I am going to talk about the trabecular meshwork approach, which is the incisional goniotomy, that is by increasing the aqueous outflow from the trabecular meshwork and Schlemm's canal by tissue removal, either by bang or KDB. So what is this bang or KDB goniotomy? Basically, you excise the trabecular meshwork tissue. This bypasses the trabecular meshwork and forms a direct pathway to the Schlemm's canal for 4 to 5 clock hours. It can be performed combined with cataract surgery or as a standalone procedure in a phakic or a pseudophakic patients. So we all know what are the indications for this incisional goniotomy, especially the most popularized. These are the two most popularized mixed surgery in our country. And any form of glaucoma, I would say we can try this procedure. Only thing is we should avoid neovascular glaucomas, and plus in angle closure glaucoma, this has to be combined with the GSL, that is the goniosynovitis. So even in failed TRAPS, mild glaucoma, moderate glaucoma, even advanced glaucoma, if the patient wants to reduce the number of medications, you can try this. It can be an indication. So contraindication, I told you, basically active NVG, corneal opacity, ankle dysgenesis, or elevated epithelial pressure, venous pressure is there in some conditions, then you should avoid it. So what is the ideal candidate? Basically the patient should have cataract. Initially when you are going to start with mixed procedure, this is the ideal candidate. Cataract plus mild to moderate open angle glaucoma. Goal should be to reduce the IOP by 20 to 30% or in mid-teens, and to reduce the number of glaucoma medications. So what are the equipments needed? Basically a surgical gonioscope, cohesive viscoelastic, Kahook dual blade for the KDB, or a 25-inch hypodermic needle. So after phaco and IOL implantation is done, you have to fill the AC adequately with the cohesive visco. To get an end-face view of the nasal angle, you tilt the patient's head away from you by 35 to 40 degree and tilt the optic of the microscope, the eyepiece of the microscope, towards you by 35 to 40 degree. Apply viscoelastic, the cohesive viscoelastic, over the cornea, and place the surgical gonio lens over the cornea and try to visualize the angle. So this way you get an end-face view. So then the central point of the nasal angle is penetrated with the tip of the bang needle or the KDB device. Thereafter it is advanced 60 degrees inferiorly and superiorly, so as to have 100 to 120 degrees goniotomy. So goal is to excise the pigmented part of the trabecular meshwork and expose the Schlemm's canal into the anterior chamber. A reflex of blood after the ablation indicates that's a good sign. That means you have reached the appropriate depth. Bang is the only low-cost mixed procedure. All you need is a 25 gauge hypodermic needle and needle holder to bend the tip. A goniotomy is fashioned by bending the distal 1 millimeter of the needle towards the bevel at about 75 to 80 degree, and this can be used to perform the goniotomy for 120 degree. So you can see in this case I have implanted the IOL. Now I am showing how to prepare the needle. So just the anterior 0.5 to 1 millimeter is bent about 75 to 80 degree, and this gives an adequate support. And this is the way you are going to prepare the basically the needle. And now once you have prepared the needle, you have positioned the patient and the microscope, apply cohesive viscoelastic, place the Schwann-Jakob lens, and try to first identify the angle structures in low magnification. Once you identify it in low magnification, you can increase the magnification and try to strip the trabecular meshwork with this bang needle. You can see as you are stripping the trabecular meshwork, you will see there is a oozing of blood. That means it's a good sign you are cutting the trabecular meshwork and you are in the right plane. So you can start this from the center point, go inferiorly, and then you can go opposite side, or you can go superiorly and again join the initial part where you are cut. So this is the way the bang procedure is done. Sometimes what happens is after this procedure there might be a good amount of oozing of the blood, so nothing to worry, you can just do hydrotamponade, and in this patient you can see that the TM strip was floating around. So with the help of a microrexis forceps or any micro instrument, you can just peel off the trabecular meshwork strip which is there. You saw in this procedure how it was done. So this is another case. Basically again after positioning and putting the cohesive viscoelastic, place the Schwann-Jakob in low magnification, identify the structures. So you can see I have penetrated the trabecular meshwork and just stripping it off. You are not supposed to be too deep, and you can see in one go how nicely the whole trabecular meshwork is stripped off. It is very easy and can be performed if you know the angle structures. Visualization of the angle structure is the key for the success of this surgery. So you should be able to visualize the angle structure adequately. So what is the advantage with this bang procedure? Because of one is the economy, and the bevel and the lumen of this hypodermic needle, they combine to form two cutting edges, and this basically forms like a double blade goniotome which is capable of excising the tissue and block. And the dorsal portion of the bent needle acts like a guard, which is the smooth portion, and it prevents incision of the posterior wall of the Schlemm's canal and helps maintain the plane of excision. Coming to the KDB goniotomy, it's a single-use disposable blade, and it has a sharp tip to pierce the trabecular meshwork. It has a ramp which stretches the trabecular meshwork, and these dual parallel blades which create a parallel incision in the trabecular meshwork. There is a rounded heel and the tapered sides, and this is a smooth foot plate also. So this gives the ease and protection to the Schlemm's canal. This is the way the instrument looks, but it comes with a cost. It costs about 30,000 rupees for this instrument. So this is just a wet lab demo of how you do a KDB. This is the demo eye. You enter the entry chamber, fill it with cohesive viscoelastic, place the cohesive viscoelastic even over the cornea, and you can place the surgical lens. This brown part is the trabecular meshwork. Now there are different techniques when you are doing the KDB. Use the KDB, you have mark and meet, you can exercise on either direction. So whichever way you are comfortable with, you can practice it in the demo eye first. You see I have marked the incision trabecular meshwork first, then I have gone behind superiorly, and then I am just extending the incision, cutting the trabecular meshwork and meeting the initial point which I marked. So this is way you can just practice your KDB goniotomy in the wet lab, and this is a live case. Again, positioning is very important, and the role of cohesive viscoelastic has to be emphasized. This is a contactless bench surgical gonioscope. It's a hands-free gonioscope. You just have to touch your finger. I have marked my trabecular meshwork. I just incised it, and now I am going superiorly and cutting the trabecular meshwork and joining the initial mark. So this is very easy, but the only problem is it comes with a cost, and there can be some complications in these procedures. Hyphema is the most common complication. There can be peripheral anterior synechiae, transient IOP elevation, and post-operative inflammation, but they are not much. So to conclude, both BANG and KDB provide safe new options for IOP reduction and reducing the number of anti-glaucoma medication. It has low risk, low cost, and it also preserves the tissue for further any glaucoma management. Thank you.
Very good. BANG versus KDB, which is more effective?
So I have done a study comparing BANG and KDB both. So at 4 weeks, KDB gives better IOP lowering, but when we compare statistically, it is not significant. And at the end of 12 weeks, both BANG and KDB has equal IOP reduction. So we won't say one is superior over the another, but when we look at the cleft, the KDB cleft is more prominent, whereas the BANG cleft is not so prominent. But I believe that once we have cut the trabecular meshwork, the collaterals open up, and that's how the IOP reduction is there both with KDB and BANG, which is not statistically significant at the end of 3 months.
Do you do post-op 2 months checkup or 1 month checkup?
So my study, I presented this in one of the conferences, and I got an award for this. I check all my patients week 1, week 4, week 12. So this is the standard protocol. If in case any event occurs, then I call them for follow-up earlier also. But my follow-up is there from last 6 months now.
Incidence of anterior synechiae and BANG?
So to prevent peripheral anterior synechiae, basically what I do is I give pilocarpine once in the night for at least 3 to 4 weeks after the surgery. So this keeps the iris away from the incised part, and the occurrence of PAS is reduced.
If there is a gross hyphema, will I give atropine or will I give pilocarpine?
No, if there is a gross hyphema, I would mind giving an atropine, homide basically, because atropine will cause more dilatation, homide will be sufficient. But there is no formation of pus even with this homide or atropine, because you are going to give it only for 3 to 4 days, and then you are going to stop it and again start with pilocarpine.
Long term, did you have any complication when hyphema is not resolved in 10 days?
Never had an issue with non-resolving hyphema. Only one patient had an hyphema which was there for at least 5 days, but at the end of 5 days the whole hyphema cleared off. This blood had oozed from the bag behind the optic also, but after 5 days the whole thing cleared off. So hyphema should not be an issue. Hyphema is more an issue with the GAT procedure, but not with these two surgeries.
Small query, any incidence of DM detachment?
Yeah, I had, so this DM detachment, my friend Dr. Devendra is there. I had shared him the picture. So during my learning curve, so I did the procedure, everything very nicely, but and I got a habit of injecting air before I close the wound. So when I injected, I realized a nice donut shaped DM was detached towards the area where I had incised. But it doesn't make a difference. You inject air, just tap the cornea and the DM gets attached, and you don't have any problem. So DM detachment, ciliary body damage can be there if your visualization is not correct. So that's why I always advocate that at least practice first gonioscopy in all your patients, cataract patients routinely. Just practice your gonioscopy and then go to intervene. Don't do the procedure without practicing gonioscopy.
How many doctors who are not doing it? Any practical tips you want to give them while doing BANG?
So that's what, first get the lens. For every Indian, cost is a factor. because if you go for the Schwein-Jakob, which will cost you 48 to 50,000, so buy the disposable gonio lens, which is available for 4 to 5,000 rupees. You can ETO it. Start practicing gonioscopy after every Phaco. What you do, not only Phaco, even if you are doing SICS, start practicing the gonioscopy. After you put the IOL, visco is there. Position the patient as I mentioned, and start practicing visualizing the structures. Once you have started visualizing the structures and you are confident, then prepare the bang needle, introduce into the anterior chamber, go towards the trabecular meshwork and just rotate. Don't cut. Your wrist has to be free. So start practicing steps first approach. So once you know that your hand is moving freely now, then you can start the procedure. But before that, start practicing without damaging the tissue.
I will just add, table has to be up, the surgeon's stool has to be very down, patient tilted out. Even in my case, we choose the location also. Like if it is a right eye, like around 4 feet for the surgeon's stool should be available.
Yeah, so what happens is once you tilt the head and the microscope, of course the position in which you have done your cataract surgery changes because the focal length changes. So you have to reduce your stool and then visualize the structure.
What I am saying is, if the two surgery tables are lying together, then it is better to do left eye on one side.
The positioning of that is like temporal SICS, two tables how you do. So your positioning of the patient has to be there properly, right eye, left eye, where you are going to position.
Any questions for Dr. Amit? Are you doing eye stent?
Pardon?
Are you doing eye stent?
I've not implanted an eye stent yet because cost is an issue at our place.
One is like anybody who's doing eye stent, you can get the eye prism from them. It is, you can ETO. Anybody can ETO. It is quite cheap.
Yeah, any disposable gonio lens which are available for 3,500 to 4,500 rupees. So there are a lot of surgical gonio lens available in the market. Ocular, Catina, you can buy anyone. National, I think North India National is the distributor for them.
The cost is not the issue. My
yeah,
message
cost is
is
not an
this.
issue. Yeah.